Hi everyone, I'm Sam, one of the consultants in Glenfield, for those who haven't met me before. Today I'm going to talk about the management of valvular heart disease. Thanks Zoe and Matt for giving me the opportunity. So the next half an hour, 45 minutes, I'm going to try and talk mainly about stenotic heart disease, but why this is relevant, obviously it's a quite common presentation. About 4% of patients older than 65 years will have some sort of valvular heart disease. We're coming across an aging population, and there is a significant number of octogenarians who need surgery, and there is a direct and indirect COVID-19 effect, obviously, on the healthcare system. So up till March this year, we had about 150 patients on the waiting list for cardiac surgery. And believe it or not, we're one of the centers that are doing quite well nationally in terms of the figures. So it's a significant workload and a group of patients that we're going to come across quite frequently. I'm a strong believer in physiology, and while intensive care is developing and the evidence is coming in multiple areas, I lived and trained in an era where the evidence was fluctuating in and out of practice. But one thing that never changed is the physiology. And I think the normal physiology is there for a reason. So in order to understand how to manage these conditions, I think it's very important to understand the pathophysiology quite in detail and able to maintain the hemodynamic targets that will keep the patient alive and surviving these conditions. As you understand, the common valvular heart disease are 4 of them, 2 stenotic and 2 regurgitant. These are the usual ones that you're going to come across. Obviously, the stenotic lesions are the condition that cause the most concern, and the reason for that concern is because of the hemodynamic effect on the cardiac output state. So these conditions will present with fixed cardiac output state, and the body will not be able to compensate for any reduction in SVR and increase in cardiac output demand. And as you understand, if you've practiced intensive care medicine, there is an extreme variety of conditions that will present with effect on both the systemic vascular resistance and that they demand increase in cardiac output to meet the body requirement during acute illness. Aortic stenosis is the most common primary valve disease, which leads to surgery or catheter intervention, both in Europe and North America. And the prevalence is already on the growing because of the aging population, which we already mentioned. The physiology associated with the aortic stenosis is mainly one that is pressure load related. So if you understand the different aspects of the cardiac circle where we go between pressure and volume changes, when you have an aortic stenosis, that will put an increase in the pressure load on the left ventricle. With time, as the body tries to compensate for that pressure load, the left ventricle will become hypertrophic. And this will start to develop a degree of diastolic dysfunction. And if people think diastolic dysfunction is a passive process, that's quite wrong. So diastolic part of the cardiac cycle by itself is an active process, and it's one that consumes energy. And if you think the longer that process develops and the more left ventricular hypertrophy develops with aortic stenosis, there will be more consumption and the ventricle will become more stiff. So something that we see quite a lot when we deal with patients who need an aortic valve replacement is some sort of diastolic dysfunction, which could range from type 1 to type 4, even a quite restrictive disease in the extreme situations. And it's not an unusual example to have patients with aortic stenosis that will have a degree of mitral regurg, which we definitely try and avoid to fix, because once you fix the aortic stenosis, that process will try to reverse itself. Why that's important? It's very important because, as you understand, the coronary perfusion pressure is usually the gradient between the aorta and the left ventricle, mainly during diastole. So if you haven't done your anesthetic exams yet, a very usual or common equation that comes across, and you need to understand the basic physics behind it, is the coronary perfusion pressure equals the aortic diastolic pressure minus the left ventricular and diastolic pressure. And so in order to maintain that gradient, we always need to maintain our systemic vascular resistance, which by itself will maintain your aortic diastolic pressure. So I don't know if you understand the capacitance and the effect of the resistance in your venous and arterial system, but that impact will have a significant effect on your diastolic pressure. It's the classic training and practice to always be concerned about the systolic blood pressure, but in my experience, sometimes in certain cases, I have more concerns about the diastolic pressure, which usually can be quite hard to control. So if you look at this chart here, which basically puts the flow in the coronary artery against time in the cardiac cycle, you can see that there is a significant drop in that flow during systole. And that's very easily explained because of the bulk of the left ventricle and the muscle contraction, which can put a lot of pressure on the coronary arteries. And the majority of that flow is during diastole. This is not true in all coronary arteries, so this is mainly for the coronary arteries that supply the left ventricle. If you compare that to the right coronary artery, which supply the right ventricle, it's usually patent throughout the cardiac cycle. And that's, again, quite easy to explain, especially in cases because of the thickness of the muscle in the right ventricle is very different, and the way that the coronary artery is built within the body of the ventricle. That equation can be affected even more if you have diastolic dysfunction in that group of patients. I don't know, you might hate this chart, and I remember the days where I had to draw it about 50 times just trying to remember it before my exams, but it puts everything together pretty much in the cardiac cycle, because it puts the relation between the pressures and the flows in different chambers and different parts of your body. And the aspect I want you to look at, and particularly for aortic stenosis, which is relevant to us, is the part here at the top, where you can see the flow in the left ventricle in relation to the flow in the aorta. So you can see there is a nice matching from the time that the aortic valve open and close between the gradient across both areas. So there isn't much of energy loss in this process. This is very different when you have aortic stenosis. So if you look here, the red one is the pressure in the aorta, and the blue is the pressure in the ventricle. And you can see there is a significant gradient from the ventricular pressures across into the aortic pressure. And the reason for that is that extra energy or pressure that's required to bypass the gradient caused by the aortic stenosis. This is very important. This is fundamental for diagnosing the severity of aortic stenosis. And the way we do that is for different measures. We either do it directly by using intracardiac catheters and measuring pressures across different chambers, but we rarely need to use that these days. So the way we do it is indirectly, either invasively or non-invasively, using echo studies. And this is what we call the VTI, which is the velocity time interval, which measures the flow across certain points in the ventricle and aorta, and gives you an amount of cell acceleration. So that amount of pressure required to bypass the aortic stenosis, which is the stricture in the system, will be able to be calculated. So if you see, for example, in this study, we have a mean pressure gradient of 44 millimeters mercury. So basically, you're going to need an extra 40 millimeters on top of what you're achieving in your aortic circulation for the ventricle to bypass that obstruction. And this is demonstrated here. This is some of the changes that will happen with time in patients who have aortic stenosis. So if you look at the circulation on the left side, which is the normal, the pressures across the left ventricular cavity and the aorta are quite equal. So there isn't any loss of energy. The ventricular cavity is nice and normal. The ventricular wall thickness is normal, and the pressure gradient across the atrium and the ventricles are normal. So what happened with aortic stenosis with time? The ventricle is not going to be able to achieve the pressure that it's aimed for to supply enough blood to the body, so it will start to get thicker and will start to build more energy. And you can see how a patient who might present with severe aortic stenosis, who's got systolic blood pressure, let's say of 120 or 130, they will have an intraventricular pressure that might reach 200 or even more. With time, as the left ventricular muscle gets thicker, will have an impact on the diastolic function. And while here is not very well demonstrated because the atrium can compensate in different strategies, initially by becoming bigger and then by becoming more hypertrophic. So there will be a thickness in the left atrial muscle as well as bigger left atria size. All these changes in the physiology can have a significant impact on the cardiac output and the supply itself. So if you look here at the normal pressure volume loop curves, you can see how different parts of the loop itself closes and open, and to sustain a circle, the circle itself is pretty much, or the area here inside that box is pretty much your cardiac output. Now that box will move into different parts of the axis to the left or right, depending on the entropy, preload, and systemic vascular resistance. So what happened with aortic stenosis is there is an increase in afterload, so this box will start to become smaller, because with the same amount of pressure, it won't be able to push the same amount of volume. Will be less volume exiting the heart to supply the body. This process might change with time. So what happens with time is you might start to move the box to the left, because as we said, the left ventricle will start to become hypertrophic. So the inotropy will increase, which is not a very efficient way, because despite the increase in inotropy and shifting the box to the left, we can see that the base starts much higher. So the preload is affected because there is diastolic dysfunction now, and the volume, the size of the box is much smaller than the original one. At the same time, you might get this, which is even worse. So with the time progress, especially if you have a coronary artery disease, in addition to your aortic valve disease, you will have a combination of decrease in compliance, so diastolic dysfunction, your preload will be affected, as well as drop in your inotropy. So the amount of blood exiting the heart will be even worse. And this is typical of the patient that we don't want to see, which unfortunately in the recent few months, due to the delay in managing these cases because of COVID, some of the patient presenting in this box. And that's quite significant, because the outcome, mortality, and all these issues are much worse than if we got them in the earlier stages. Is everything clear about the physiology? Because this is really important. Does anyone have any questions before I go into evaluating these patients? I can't see any hands. Okay.
I think we're okay, Sam.
So how are we going to evaluate these patients? There is a recent update to the American Heart Association and Association of Cardiologists, which came, I think, last year, 2020. You can imagine a lot of cardiologists sitting doing nothing because of COVID, so they won't need an invitation to come up with a new massive guidelines. They updated their guidelines from 2014, I think last time was published, and all the recommendation, one of the major recommendation is that the disease stage in patient with valvular heart disease should be classified into 4 stages, A to D. The basis of the classification should follow symptoms that patient present with, the valve anatomy, the severity of the valve dysfunction, and the response of the ventricle and the pulmonary circulation. So history and physical examination are very crucial actually in this group of patients, and the findings should be correlated with the results of non-invasive testing. So when you come up with these patients and you come to see them either for valve surgery or for any other non-related issue, just an ICU admission, it's very important to correlate what history they present with the ECG, chest X-ray, and transthoracic echo. Only if there is disagreement between these two, then you start to consider more invasive or non-invasive methods like TOE and cardiac MRI and all that stuff. Very important when you assess them is to have a degree and an understanding of risk stratification, and this is not just related to the valve, this is related to the whole process of the disease and the aging. So the risk stratification is essential, because if you can't balance the risk benefit of an intervention, you won't be able to justify it, because that could be just a natural disease progression. The problem, these are a very complex group of patients, and the outcome prediction is not always easy, especially when they present for non-valve condition. So general ICU scores usually don't apply very well in patients with valvular heart disease, because they very rarely take this into account. What's really important is the symptoms in addition to your risk stratification. So a lot of these patients will have a latent period, which could be anything 20, 30, 40, 50 years, where there is an increase in obstruction and myocardial overload, but they won't have any symptoms. At the point they start to become symptomatic, then that's when we worry really, because you can see very clearly from the other chart here that once they start to develop any symptoms of angina, if you continue the disease progression without treatment of the aortic stenosis, pretty much all of them will die within 5 years. If they start to develop syncope, then they will be pretty much dead within 3 years. And once they start to develop heart failure, if you remember the volume loop curves I was talking about, pretty much they will die within 2 years. So we really want to be getting them as early as possible in their symptoms, rather than waiting for the disease progression where the condition becomes irreversible. And the mortality, the acute and chronic mortality, is much higher. There are specific cardiac scoring systems. This is a list of some of them. Maybe you heard of the Euroscore, the CARE score, and the SDS. The others are less commonly used, and to be honest, we don't use them. The one I would say that you can easily access it online, and you can put it if, for example, you get called to the ward to see a patient who needs an ITU admission for any purpose, rather than valve surgery, and you're not sure about how bad is his valve condition, you can use the CARE score, which you can put it online. It gives you a rough idea, but I wouldn't trust it 100%. It's been validated against the Euroscore, and it does show similar accuracy, but we just have to be careful because the number of patients studied is not massive. What it doesn't account for left ventricular failure and the age, which for me is a major thing. Euroscore has been established for more than a decade now. It's based on big number of patients, more than 20,000, and it's been collected in multiple countries and hospitals. So it's a big major score that all of our cardiac surgeons use and give to the patient. And the same for North America is the STC. It's been established for longer than that and has the biggest data set in the world at the moment for cardiac surgical patients. So they can be used for other additional comorbidity as well as mortality figures. Pitfalls with all these risk scores is they miss quite important intra, pre, and post-op factors, which can have a major impact on morbidity or mortality. Particularly factors of interest to me is frailty, BMI, things like porcelain aorta, bypass time, and cross-clamp. But we all know that all these factors are quite important in deciding the outcome. So, for example, I don't know if you know, but severe morbidity can reduce life expectancy by 10 years without any pathological conditions anyway. So what the true value of these risk scores? If you can't use them to justify how you're going to use that intervention for that specific patient, their predictive value is useful in deciding the indication for certain surgeries, the estimating for resources, and some, well, we use them for the proper concern to the patients, to be honest, but it's very hard when you have a discussion with that patient, when you tell them like your mortality after cardiac surgery is 1 or 2%. So what does that mean really? I mean, you could be that one single person. So you never know, you can't, it's a population risk factor rather than a patient risk factor. So I always tell them that when I have my informal consent with them. Other one which you have to bear in mind, and there's a lot of talk, is about frailty. So as we're dealing with an aging population, for example, in Glenfield, the last audit we did, we had about 10 to 15% of post-cardiac patients who were octogenarians. This is not different from the national average, it's not far from it. They have fewer comorbidities, but they will have a higher disease severity. So therefore, this is very important really, because this is what we call a high risk, high benefit group. So what does that mean is, while these are high risk cases, if you treat them and you select them very well, they will have a normal life expectancy as anyone in their age who doesn't need that surgery, if that makes sense. So we shouldn't deny these people surgery or admissions based on that single factor, as long as obviously everything else is fine and they're not frail. And that's what happened in Glenfield and many cardiac centers. So these people, before they present for their cardiac surgery, they will have a frailty assessment, and they will be classified into different pathways, because as you understand, frailty is multifaceted, multifactorial pathology. And when you reach to the stage where you have enough comorbidity with the age, make you frail, and you just get an acute interventional illness, you'll have an ongoing comorbidities, and mortality will be very, very high. So, coming now, we looked at the history, some of the factors that help us to decide the risk assessment and risk evaluation. I can't say how important it is really, and state how important it is to look at the ECGs. So I know everyone is excited about echoes and doing echoes and all that stuff, which is very important in this group of patients, but looking at the ECG, in my opinion, is very important, especially when you do some non-cardiac surgery on these patients. So for example, here in this ECG, you can see very clear evidence of left ventricular hypertrophy, and potentially there is an evidence of P pulmonale, which is left atrial enlargement. So these are the kind of things that tells you that this patient will perceive more problems and more risk of having complications after even going in and undergoing an elective day case surgery. So this is something you should bear in mind, especially if these guys have not been seen before, nobody listened to their chest, they've not had an echo. So have your inspector eyes and always use these triggers to get you into a safe place. This is even worse. These patients will have a left ventricular hypertrophy and strain pattern. So this in particular will be quite concerning. And this one as well, when you have ST changes and T-wave inversions and all that stuff. So that's what I'm saying. Your ECG plus your clinical picture will give you a very, very good guide of what you need to do for these cases and how to approach this further. After that, obviously, echocardiography is the cornerstone of evaluating these patients. And then we can do some additional tests, which we rarely need to do really, but we have a group of patients who come with cardiac MRIs, multi-slice scans, BMPs, very rarely catheterization. Exercise testing in cardiac patients is a bit controversial because it's a high risk. So the echo is important because it's a diagnostic tool. It assesses the severity, assesses the left ventricular function, and it will carry prognostic information. And also will give us an idea about any other associated valve pathologies. So echo measurements that we use, they're split into direct and indirect measurements. So the direct measurements, one of them is the aortic valve area. And when I talk about the aortic valve area here, I mean planimetry. So basically, you draw the circle where the commissures of the aortic valve meet, and that will calculate the size for you. Because the other way to measure the aortic valve area is the indirect, which is using the VTI, the velocity time interval, to measure the gradient of pressure across the areas, then measuring the LVOT size, and that will give you the size of the aortic valve. You've all seen, I'm sure Hannah and Gary will show you a lot of echo images in the echo rounds, but if you're not part of them, please join, because there will be a lot of learning and opportunities. It's one skill that's, I think, fundamental for future intensive care. This is what I've been talking about, the velocity of flow of the red cells across the aortic valve. So in this patient, for example, we have a mean gradient that's ranging between, I don't know, 30 to 60, and that's possibly because he's in AF, so he's got irregular heartbeat, his preload is irregular, so hence the change. In these cases, you have to take a group of these VTIs and average them to get to the mean pressure. So looking more depth and more detail about aortic stenosis, there are 4 different categories. And these are the high gradient aortic stenosis, which is the straightforward. But then we have 3 others, which are low flow, low gradient with reduced ejection fraction, low flow, low gradient aortic stenosis with preserved ejection fraction, and normal flow, low gradient aortic stenosis with preserved ejection fraction. And I know it can be confusing and a little bit muddled when you talk about these, but it's very important to be able to differentiate where your patients sit in which one of these categories. Because for one reason, some of them can be missed and undiagnosed, and for other reason, it carries quite significant effect on prognosis and the type of surgery and organ support that you can provide these guys. So these are the 3 different categories of low gradient aortic stenosis. And when we mean low gradient, we're talking about gradients of less than 40 millimeters mercury. That's a mean pressure gradient. So then you split them into category with reduced ejection fraction, which usually doesn't need surgery and need to be investigated further, and another category which with a normal ejection fraction. So we'll go through these. So the normal straightforward one is the high gradient, and this is where you measure directly or calculate the valve area less than 1 with a mean gradient of more than 30 to 40. It depends on which book you read, but most books will agree more than 35, 40 is a high gradient. The low flow, low gradient aortic stenosis with reduced ejection fraction. This is the one that you measure the valve area less than 1. And the mean gradient is less than 4, with an ejection fraction is less than 50%, sorry. And the stroke volume index is subnormal. So these patients are usually a group of patients who will have myocardial disease. And what I mean by that, heart failure. And this is what we call pseudo-severe aortic stenosis. And what that means, once you start to give them inotropes to help their myocardium to eject and put enough pressure in the left ventricular cavity, then the cusps will open fully. And suddenly you will see that the valve area will go more than 1. So this is not true aortic stenosis. This is a myocardial disease rather than a valve disease. So the low flow, low gradient aortic stenosis with preserved ejection fraction. This is really worrying for me, and I think for most anaesthetists and surgeons who deal with this disease. This is the one where you have a valve area less than 1, gradient less than 40, and ejection fraction more than 50% with the low stroke volume index. So what we mean by that, if you look at this shape, so what you will see is, this is typically the old little ladies in their 80s with aortic stenosis that's classified moderate to severe. And when you go to echo them, what you will see a very severe left ventricular hypertrophy with massive left atrium. So what happens with time, because this lady has a severe aortic stenosis, she will compensate, as we said, by ventricular hypertrophy. So her cavity size, will go, let's say, instead from 15 mils to 30 mils, because the rest of it is filled with a very hypertrophic muscle. She will develop a very severe diastolic dysfunction, which will have a significant backflow to the left atrium, causing a significant dilatation and left atrial hypertrophy as well. So these patients, when you have any issues with them, and not just related to their systemic vascular resistance, also related to their preload, they will struggle, because once that massive left atrium doesn't get enough volume, the preload will struggle. The ejection fraction is very small, so there won't be enough cardiac output to sustain viability. So these are the ones that I'm most concerned about, really. This is the kind of image I was talking about. So if you look here, look at that very small ventricular cavity, very thick left ventricle, very dilated left atrium. You always have to fill these guys well, because any compromise in the filling, they will feel it very badly. And you'll start to go into a cycle of collapse of the cardiovascular system that you can't reverse. So the final one is the normal flow low gradient aortic stenosis with preserved ejection fraction, and this one is where the valve area measured or calculated is less than 1, mean gradient is less than 40, and ejection fraction is more than 50% with normal stroke volume index. These patients will in general have only moderate aortic stenosis, so they usually will not need a surgery for their disease. This is a chart. I'm not going to go through it, but it's basically how you're going to assess all these different types and kinds, because it's as we said, it's very important to have a classification. This is a conundrum that happens sometimes in theatre, so I have to go through all these different steps to be able to identify, because first, you don't want to operate on the wrong valve, and second, the hemodynamic management, while it feels the same, is very different between these two groups. I always worry about the one which I mentioned about the small ladies with a very hypertrophic left ventricle and small ventricular cavity. So if you're still not certain, you can use some additional diagnostic measures. I said exercise stress is unusual. We don't use it a lot. We still have a place for it. TOE pretty much give you the same what transthoracic plus some additional visibility because of its axis and angles and everything in planes. MRI can be used to be quantified in myocardial, because especially this is important if you have a condition where you have a joint coronary artery disease and you're not certain if the drop in the ejection fraction is because of the valve itself and heart failure, genetic heart failure, or is it because of established myocardial infarction and replacement of the myocardial sides by fibrotic tissue. So how are we going to intervene? We need to treat basically as early as possible all symptomatic patients with severe aortic stenosis. The ones that we shouldn't offer them treatment is the ones who have severe comorbidity indicating survival of less than 1 year. And if they have a general condition at advanced stage that make it unlikely the intervention improve quality of life or survival. So it's not just survival, quality of life. There is no low ejection fraction limit in high gradient. So if you have someone with a high gradient aortic stenosis generating a pressure of 40, it doesn't really matter what their ejection fraction, because if they're generating that pressure, it means their ventricle, once you solve the problem, which is the aortic valve, they will always have a better cardiac output after the valve surgery. In patients with the low flow, low gradient and reduced ejection fraction with predominantly caused by excessive afterload, function improved by intervention. So that's the other group of patients which we always said treating the valve will still help their condition. Okay. If you're not certain, you need to investigate it further, and any interventions definitely advised when severe aortic stenosis conferred at increasing flow, true severe aortic stenosis. Okay. I don't think we need to go this. Forget that. So, get that. That's pretty much another chart of how you're going to categorize these guys and what treatment you're going to offer them. Is it a medical therapy? Is it a TAVI, or is it a surgical AVR? So just a brief discussion, and I'm about to finish, about the choice of intervention. So the choice of intervention takes into account the cardiac, extracardiac characteristic of the patient. This should be decided by a heart team, in addition to score and feasibility of TAVI, and should be based on the center outcome data. So let's say, for example, Glenfield is a very high load TAVI center. Our outcome data might be very different to a center in Newcastle or Papworth or somewhere else. So that category should take that into account as well. So just to let you know that medical therapy for aortic stenosis doesn't have an impact on outcome compared with natural history. So if they have aortic stenosis, and I don't know where you want to give them amlodipine or ramipril or whatever, and aortic stenosis is the cause of the problem, you might as well give them nothing, because they will die at the same rate. There is a randomized trial that haven't shown that statins do affect progression of aortic stenosis as well, so that's something else to consider. Patient with symptoms of heart failure who are unsuitable for TAVI or surgery should be treated with heart failure guidelines. So you just apply the same heart failure guidelines in your treatment. Coexisting hypertension should obviously be treated. Medical treatment should be titrated, because as we said, you need to avoid hypertension, and patients should be evaluated frequently. And it's really important as well to maintain sinus rhythm in this group of patients. Surgical AVR is better than TAVI in patient less than 75 and low surgical risk group. TAVI is developing quite a lot. So even since I started doing this specialty, I don't know, about 5, 6, 7, 8 years ago, TAVI has developed quite significantly since that short time. So the criteria for applying TAVI in surgical patient is increasing on the day. I think this should be all right. So a symptomatic patient is a little bit more of a challenge. So because, you know, if you diagnose for certain reason, like went to your GP for a relevant problem and he listened to your heart sound, diagnosed aortic stenosis, and he echoed you. So you get an annual echo or every other year just as surveillance. So this group of patients is a little bit more difficult to manage, but we usually don't. There isn't enough data to provide evidence to support surgical AVR early in these patients who are completely asymptomatic, regardless of the severity of the aortic stenosis. So it should be very careful weighing of balance of risk and benefit, and this should be taken by a team. So TAVI for this group of patients, it's not recommended definitely. Early elective surgery is only indicated in a symptomatic patient with depressed left ventricular function, which you genuinely think is due to the aortic stenosis rather than a myocardial disease itself. And these are basically the hemodynamic goals, which I didn't go into details, but if you understand the pathophysiology of aortic stenosis, this is what you should aim for basically. So you should always try and keep the heart rate with the normal to help the diastolic time. You should always try and maintain sinus rhythm just to help with their preload and maintain cardiac output, and always adequate volume loading, so preload to main cardiac output. Always maintain high to normal SVR to maintain coronary perfusion pressure during diastole. Any questions? Or have I stunned you into silence?
A little bit, I think so.
Is it too complicated or not?
No.
Most of what we talked about is pretty much in this guideline. That's what I was talking about, but then they updated it last year while we were busy trying to deal with the COVID cases. So get the new updated guidelines. And there is also European Society EACTS guidelines for management of heart valve disease. So the way I looked at this, guys, basically I tried to get you the normal history of pathophysiology, being comfortable with risk stratification and being able to diagnose the problem. But don't forget that aortic stenosis is a spectrum. In a way, it's a syndrome. It's not a single condition. So one patient with aortic stenosis is very different from another one. And if you have a patient coming, for example, to have his hernia done under anesthetic, who's got severe aortic stenosis, who's completely asymptomatic with normal ECG, it's very different to someone who's coming because he's septic, he needs an ICU admission, who's 85, who's got severe aortic stenosis with obvious signs of strain on his ECG. So this is very different patients to each other.
That's what I was going to ask you, Sam.
Yeah.
Whether in anaesthetics, if I have somebody that's asymptomatic, then I tend to mostly ignore it within reason. But if how would you manage it differently on ice? On obviously we don't have TOE and cardiac surgeons to back us up over here, but just stick with the hemodynamic goals you said in your last slide, basically keep them slow and tight.
Yeah, I mean, the thing is you have to think about, Zoe, is if they're coming for certain surgery and they have a diagnosed aortic stenosis, but they're completely asymptomatic and they're living their life, they're not going to have a valve surgery. So if they need that hernia, it's much better to do it while they're still stable rather than coming as an emergency middle of the night obstructed hernia. But you will take all the precautions to deal with them as a cardiac case. And I'm not saying TOE and all that stuff, but maybe it might be a big kill to have an arterial line, but possibly you might want to consider it for that patient. Yep. Running a bit of phenol on the background, keep the blood pressure stable, keep the heart rate stable. I find phenol is a extremely good mix for these guys because they keep it slow and normal.
Yeah. Fair enough.
But I get to worry when I see ECG changes really on the ECG because it means that the heart muscle is not happy. There is something in the background which we haven't diagnosed properly.
Yeah, we see them. I suppose the common ones that we'll see are the post-op laparotomies that are a bit septic. You've got a background of aortic stenosis and nobody ever seems to know how bad it is. It's usually the ones we see. And they're usually quite hard to keep slow because they're a bit tachycardic at that point. Do you ever slow them down or do you just let them?
I would. On very few occasions, I've given a myodrome, which I know sounds counterproductive, but you have to do everything to try and keep the hemodynamics stable, really. We'll cardiovert them in Glenfield if
obviously if they're in AF, then that's or whatever, then that's slightly different. But if it's just sinus tachy, do you slow them down? Yeah,
I'll try and slow them. Obviously, if there's hemodynamic effect, if there isn't, then you can tolerate it as it goes.
Yeah, fair enough. Thank you.
I hope that's good. Thank you.
Okay, great. So, if anyone doesn't know me, I'm Matt Bigwood. I'm one of the FP6 analytics trainees at Glenfield at the moment. And I was asked to talk about the 65 trial. Some more cables. Okay. It was published in the Journal of the American Medical Association in February last year. So most of us had other things on our minds than to look into this. I'm basically asking the target we set for arterial pressure in older patients on the ICU on ventilators affects the mortality. So for those of you who the presentation is going to be too long and you don't want to read about this, the question was, does reducing radius pressure exposure by reducing that target in to 60 to 65 in that older age group improve the 90-day mortality with people with vasodilatory shock? The answer is not significantly, but probably doesn't make it any worse, and it may make it better, but we'll have to go into the paper a bit more to know that. So vasopressors are very commonly used in intensive care, as we know, to prevent hypertensive-related cardiac, kidney, brain injury, and ultimately death. They do not, however, come without side effects, mainly caused by reduced blood flow in very constricted vascular beds, causing adverse effects, for example, gut or limbs. The surviving sepsis campaign gave us a target mean arterial pressure of 65 based on just, so you can work out whether just is good enough in expert opinion, and suggested an even higher mean arterial pressure for older or comorbid patients, although they did acknowledge in 2017 that there's no evidence for higher targets in any patient group. There was a meta-analysis done by, of note, the same author as this 65 trial, of 2 papers called Sepsis, PAM, and Ovation, with the Ovation trial again by the same author, so we know he's got a pet topic, suggested mortality in greater than 65-year-old subgroup was higher with a higher targeted mean arterial pressure, and therefore, obviously, they've got more vasopressors. The numbers for your knowledge was 48.5% versus 37.2%, and so that result is what made them do the 65 trial. So if we go into the trial, it was a pragmatic, open, it's not blinded, multi-centre. Interestingly, there was 65 sites across the UK. It was a parallel group randomisation, obviously a randomisation controlled trial. With equal numbers randomised to control and to intervention group. And it was possible to be randomised 24 hours a day. It finished just over 2 years ago. They also enabled recruitment before consent if they were able to get it and later gained it from the patient or a relative. They performed an interim analysis to ensure no harm, and the final analysis was on an intention to treat basis. So the intervention group was permissive hypotension, or pH, in the rest of my presentation. The targeted mean arterial pressure was 60 to 65 millimeters of mercury, and the line limits were adjusted to allow timing changes in the doses of vasopressors. The control group was usual care, where the vasopressor dose was totally at the discretion of the clinician, taking into account any factor and using any target, any parameter. All other management decisions were at the discretion of the clinician, including type and number of vasopressors in both groups. The intervention continued for the patient's entire length of stay in intensive care, and for the purpose of the trial, noradrenaline, vasopressin, terlipressin, phenylephrine, adrenaline, dopamine, and metronidazole were considered as vasopressors. So we can all have a chat about that. So inclusions, well, obviously they need to be over 65 years old. That was my point of the trial. They needed vasopressors, and they needed to be on them for less than 6 hours to prevent any pre-randomization effects. They needed to be not hypertensive from other reasons, i.e. fluid depletion, and likely to need vasopressors for more than 6 hours to enable time for intervention to have an effect. People that were excluded were the ones who had contraindications to permissive hypotension, including brain and spinal cord injury, other causes of shock, so for example bleeding and cardiac failure, or post-cardiopulmonary bypass, and also when death was deemed to be imminent, or they had previously been recruited to the trial. So this is a picture from the paper. I don't expect you to read it, but basically there were 2,600 patients were randomised, of which 2,463 were included in the final analysis. And the baseline variables between the two groups were well matched, apart from the dependence with ADLs, which there was more in the permissive hypertension group, 30%. So if we look at how the two groups were managed, there was a divergence in both exposure to vasopressors and the mean arterial pressure in the two groups. But I guess it's the whole point of the trial, so at least they got that right. Although, interestingly, the mean arterial pressure in the greater than 65 was greater than 65 in the permissive hypertension group, which obviously the whole point of the trial was to get it between 60 and 65. So we'll talk about that again in a bit. So if you look, the median duration of vasopressors was 5 hours in the pH group, and the mean total dose in noradrenaline equivalents was 8 milligrams less in the hypertension group. They got less time and less doses of vasopressors. So here's a graph that I found in the kind of added figures addendum page. I couldn't find the raw data that informs this graph, unfortunately. So it shows the mean hours, and this is the left-hand pair of that graph, and the percentage of all treatment hours, which is on the right-hand side, at various map values with both groups. Paper states there was no significant increase in mean arterial pressure. Sorry, let me just get this right. This is very important. So the paper does say that there was no significant increase in the time. The mean arterial pressure was less than 60 in the permissive hypertension group, which is represented here by the purple bars on this graph. You see there is a slight difference, but as I said, I can't see the numbers. I couldn't find the data for this graph. Paper also states that 11% of patients in the permissive hypertension group had one or more episodes of non-adherence to the protocol. That is, i.e., the mean arterial pressure was above 65, and their vasopressin dose was not reduced. And that's either due to clinical concerns or logistical or staff-related reasons. Then it goes on to say, and I'll quote, overall non-adherence represented 6% of the total time receiving vasopressors. But if you look at this graph, the amount of kind of light yellow arrow and the red arrow, so the kind of medium blue, the dark blue, and the navy, it looks to me to be a much larger proportion than 6%. I'd say if someone can work out or give me any reason or any excuse or possible explanation of why that is, the only thing I can think of is that they've used all the hours that both groups were on vasopressors and then taken those hours as a percentage of that, because, like I say, otherwise that can't just be 6% of the total time. So to me, it's more than, it's like at least almost half the time the permissive hypertension group were out of range and nothing was done about it.
Do you think they could be off vasopressors and read, so they've got a blood pressure like a map of 65, say, and they're actually off the NORAD by that point, so therefore out of range, but they can't reduce it? I don't know.
Yeah, that's a very good point. But yeah, so they do quote 6% over time, but they're clearly out of range more than that. Whether it's their own doing. So here's the results. So 90 days, there was no statistical significant difference in all-cause mortality. There was a slight absolute risk reduction of 2.8%, but 95% confidence interval crosses 0, so the p-value is greater than 0.05. Sorry. If you adjust for the pre-specified baseline parameters, the confidence intervals and the odds ratio does just get below 1. But there's edging towards significance, but that is with fudging the numbers slightly in statistics. If you look at all the secondary outcomes, again, there was no difference in the secondary outcomes. Again, the tables from the paper, but I don't have to read. The only one that was not way above a p-value of 0.05 was the cognitive decline at 1 year, which is slightly worse with permissive hypertension. The p-value was exactly 0.05, which they do not mention anywhere in the paper, in the actual text. If you look at the adverse outcomes between the two groups, they were not different as in raw percentages, but they had different types of complications. So the permissive hypertension group had more AKI, but had less mesenteric ischemia, and you can obviously work out the biology behind that. So they did some subgroup analysis, and the only subgroup that had a significant interaction between which group you were in was the chronic hypertension group. But it was actually the opposite of what you'd expect. The reduction in 90-day mortality was more pronounced in the permissive hypertension group, i.e. patients who had chronic hypertension who were then randomized to permissive hypertension actually did better, with their odds ratio of 0.67. I can't really see a logical biological basis for this, although we'll discuss some things in the end. So the paper just states some limitations on the screen there. I don't think they materially affect the results or any of the conclusions. So let's move on to what I thought. So this is what they say as their strengths. They say that it was well run, it was big, it was good follow-up. They had a year follow-up to get the cognitive decline and quality of life, which is important to patients as well as survival. They argue that permissive hypertension in the age group is unlikely to cause harm, and that one parameter of mean arterial pressure outperformed clinicians that were able to use multiple parameters to titrate the vasopressors. They do agree that the chronic hypertension result is confusing, but it was not powered to detect this significant difference, therefore more data is needed. They also hypothesized that being classified as chronic hypertension does not guarantee exposure to hypertension, i.e. you could be well controlled on your medication, and also being classified as normal tensive does not guarantee non-exposure to hypertension, i.e. failed diagnoses. And the final conclusion is obviously there on the screen. It says, to look at the numbers rather than whether it or not it was significant. So my thoughts is that every trial will always say, look at our numbers if they don't quite reach significance but show a possible connection. But I would be more inclined to agree with the conclusion. If the permissive hypertension group had a lower mean arterial pressure, which remember was 66, and also spent more time in target range, let's say, again, we saw that there were more than 40% roughly outside of the target range. And also, if you think the non-adherence was due to clinical concerns, so was that clinical concern non-adherence, was that in the hypertensive group? The chronic hypertensive group, the people were worried about even though they were in the trial, about having them with a low arterial pressure. And so was that skewing the advantages of the hypertension group to chronic hypertensives? Again, the paper doesn't say, it doesn't go into that. So if you look at the data, I think this trial was really comparing mean arterial pressure of just over 65 and then mean arterial pressure of just over 70. So it does give me confidence to not, in a greater than 65-year-old, not aim for supernormal or super 65 millimeters of mercury arterial pressures, but it wouldn't make me super confident in aiming for less than 65 millimeters of mercury as my primary target. So that's my run through the 65 trial. Any questions?
I've got 2 comments.
More comments? Yes.
So I do think that we need to move towards like personalised blood pressure targets a bit more. So the meta-analysis you talked about showed that the higher blood pressure you target, the more NORAD you tend to get, obviously, and the more AF you get. So it's not a harmful intervention, just to randomly target a higher blood pressure.
Yeah.
And then I also find it so true that we talk about people who are hypertensive patients, that they should have a higher blood pressure. But people who've got a label of hypertension are the only people who are going to the GP regularly, having their blood pressure checked and having their blood pressure medications titrated to achieve a normal blood pressure. And so people who haven't been to the doctors for 5 to 10 years and don't have hypertension, who actually probably don't have auto-regulated to a higher blood pressure. So I do think we need to sort of maybe think a bit more about what is the person's normal blood pressure, or like what the GP says, when you go to the follow-up checkup clinics, what is their blood pressure, rather than sort of grouping all. They've got a label of hypertension, so therefore, despite their medicine, they clearly must be really hypertensive and they warrant a higher blood pressure.
Yeah, it's difficult to know, as I say. You can have people who went to GP once, got their amlodipine, and hasn't been back since, and therefore could have uncontrolled blood despite the label. But equally, there's all the combinations of on and off medications with high or low blood pressure.
There was an anaesthetic trial, I've forgotten the name of, that they looked at titrating blood pressure target intraoperatively towards either personalised targets based on what their outpatient blood pressure was versus just a random systolic of more than, I've forgotten what it was, 120, 140 or something.
Yeah.
But I do, that is an interesting topic, and I think, like many things, personalised medicine is the way forward. And when med students ask us, why 65? I think that's a great question.
Good question, absolutely. And so just to have on the screen, there's the PDF that they produced. for tomorrow. Anything else? Any other comments, questions? Hi. Is that someone? Yes.
I think me and Ricky have a couple of comments. Does Ricky want to go first?
I think you got your hand up first, Sam. Go for it.
Oh, I don't know. I'm with research, but this particular paper, it's pretty much telling us what normal physiology does. So if you think about me sitting here during the day, my map goes between, I don't know, maybe 40 to 100, depends what I'm doing, what I'm eating, what I'm talking to, what. So I don't know how you're going to be that descriptive in an intensive care unit when you have multiple comorbidity and conditions that changes all the time, including infections, non-infections, AKI. So in a way, we're still aiming for this super physiological figures, which never made sense to me at all. So during my anesthetic and intensive care practice, the only thing that keep proving itself to be functional is having a normal physiology. So I think just aiming for a normal map within a certain range that's acceptable for me is the way forward. But obviously you have to adjust that and take it into the patient consideration and the disease progress at that certain point, because no matter how good your study design is, I don't think you can put statistical methods to account for all these. So that's why I don't make it. And Eden made very valid point about the group that were outside the target for a longer time, and that potentially could be because they were hypertensive. So potentially this group of patient has a more end organ disease, end organ damage, and that potentially is something that we haven't counted for, because I assume they haven't done renal biopsies and echoes and all that massive investigation for all these group of patients. Well, thank you very much. Very interesting paper. It's good to look at, I mean, how different practice and small changes. So in my opinion, I think the change is too little to make a valid change to outcome.
Yeah, I think my comments were, I think it's quite an interesting paper, just the fact that it is another one that's sort of showing kind of less aggressive therapy doesn't really, cause adverse outcomes really. And, we still get sort of patients land on the ITU and, we sort of, someone might say, well, they're on, antihypertensives or they've got that label that you talked about of hypertension. Should we be aiming for a higher MAP? But I think this paper is pretty reassuring that, to be honest, aiming for 60, 65 is absolutely acceptable. And certainly my practice now is, I tell the nurses I'm happy with 60, run them at 60 for a bit. If they don't, if there's sort of signs of shock, then you might go up to 65. But I'm pretty happy just to start at 60 and go from there, really.
You can also use other parameters. You don't have to just go on the map. So if they're not passing urine or if they're not celebrating, then yeah, you can increase if you need to. But to have somewhere to have the confidence to start it just normal, as in what we do for everyone, probably is reassuring. Yeah,
absolutely. Yeah, obviously if there's signs of hypoperfusion, then we sort of crank up things and go a bit higher. But yeah, patient lands on there, aim for 65 if they're septic, and fairly happy that we've got evidence to support that.
I think use common sense. That's what I try and do when I'm doing on intensive care or in anaesthetics. Just try and keep them normal, be common sense about it.
Sorry, quick point. I forgot to mention. I don't know how they selected their vasopressors. When you look at adrenaline, you said dopamine as well. Which, yeah. Adrenaline, I mean, it's very hard to judge because it depends on the dose for that patient. It could be anything from pulmonary vasodilator to inotropy to vasopressors. So
I thought that might come up. The long list of things that they used as vasopressors, especially in this site, was long. And that vision was up to the clinician at the time. So all they've done is converted everything to northern limb equivalents. However, clearly there's a table somewhere to do that, and that's what they used to work out how much everyone's getting. Yeah, good point.
So my name is Jay. I'm one of the stage 4 JSF lecturers at the moment, and I've been asked to speak on this paper which was published by the Community Journal in June, essentially looking at left atrial appendage occlusion during cardiac surgery to prevent stroke. Before we delve in, just a bit background. So AF is common in elderly patients and is responsible for quarter ischemic strokes, and many of which are cardioembolic in origin and originating at the left atrial appendage. Normally, oral anticoagulation reduces thrombus formation and has been proven to prevent and be effective in preventing ischemic stroke in AF. However, it's limited by non-adherence to prescribed medications, discontinuation of drugs, underdosing, or in case of vitamin K antagonists, poor control of the INR. So, left atrial appendage occlusion is hypothesized to reduce the risk of stroke in patients with AF, but this hasn't been proved yet in a clinical trial. So, this study, which is the left atrial appendage occlusion study 3, was done to evaluate the efficacy and safety of concomitant atrial appendage occlusion in patients with a history of AF undergoing cardiac surgery for another indication. And specifically, the primary outcome was to look at whether it would prevent ischemic stroke or systemic embolism. Just a word of note, the left atrial appendage occlusion study 1 and 2 were done in 2005 2013 respectively. The one had just 77 patients looking at the safety of this procedure in CABG operations, and study 2, which was done in 2013, was a cross-sectional study, which had about 300 or so eligible patients, which essentially explored the feasibility of a larger study in the future and whether that would be safe, which is this study. Moving on, so this was a multi-center randomized trial. It included patients who were 18 or older, who were scheduled to undergo cardiac surgery with cardiopulmonary bypass and had a history of AF, and the CHADVAS score was at least 2. The CHADVAS, as we know, includes congestive heart failure, hypertension, age, diabetes, stroke, TIA, or vascular disease. They excluded off-pump surgery, mechanical valve implantation, heart transplant, pericardial surgery. The patients were then randomly assigned in a 1:1 ratio with a web-based randomization system to either undergo or not undergo occlusion of the left atrial appendage. This study was blind in the sense that participants, trial personnel, and clinicians caring for the participants were unaware of the trial group assignments. Obviously, this didn't include the surgeons for obvious reasons. The surgeons were then not involved, and neither were the operative teams involved with ongoing management or antithrombotics or further collection of data. So the techniques that were used for appendage occlusion included amputation and closure, which was the most common preferred one, stapler closure, double layer linear closure, and use of an approved surgical occlusion device. And an intra-op TOE was done to confirm successful closure. If the initial closure had failed, additional maneuvers were then performed immediately to rectify the failure. And if a patient had a thrombus identified in the appendage, the left atrium was open to remove the thrombus before occlusion. Participants were then followed up by telephone or in person at 30 days, and then every 6 months till the end of the trial date, which was in January this year. The primary outcomes that we were looking at was the first occurrence of ischemic stroke, which included TIA with a positive imaging, or non-cerebral systemic embolism during follow-up. There are other secondary outcomes like any form of stroke or systemic embolism, ischemic, or death from any other cause, 30-day mortality, chest tube drainage, in the first 24 hours, any chance of heart failure or re-exploration of bleeding in the first 48 hours. Just to be clear, the data that was collected by trial personnel was on anticoagulation use, and if a patient wasn't receiving anticoagulation, the specific reasons for doing that were documented, and there was a validated stroke questionnaire to determine if any symptoms indicating a possible stroke had occurred. And all of this was compiled and then reviewed by stroke neurologists. The primary hypothesis of the study was obviously that the risk of stroke or systemic embolism would be lower in patients with surgical occlusion done, which was added to the usual care, and with no occlusion added to the usual care. The results, which basically the primary analysis population included 2379 patients in the occlusion group and 2391 in the no occlusion group. The study was conducted from over 6 years, from 2012 to 2018. The trial groups were balanced with respect to baseline characteristics. The mean age was 71, 67% were men. The mean CHA2DS2-VASc score was 4.2, and about half the patients were already receiving anticoagulation at baseline, and they were followed up for a mean of just under 4 years. So I don't know if you can read. This can be read. It's probably cannot. Then basically, this shows that trial outcomes, the primary trial outcomes, which were presence of ischemic stroke or embolism. So overall, there was a 4.8% of these events seen in patients who had the occlusion, as against 7% in those without the occlusion, which was statistically significant. The secondary outcomes, again, the incidence of post-op bleeding, heart failure, or death did not significantly differ between the two groups. And the effect of the occlusion on the risk of ischemic stroke or embolism was consistent across all subgroups, which was done on further analysis, which included sex, age, presence of other diseases, CHA2DS2-VASc score, etc. So in this study, amongst patients with AF and the risk of stroke, the risk of outcome of the ischemic stroke or systemic embolism was lower with LAO occlusion performed during cardiac surgery. The number of participants needed to undergo the occlusion to prevent one stroke over a period of 5 years was calculated to be 37. There was no significant increase in the risk of heart failure or major bleeding. So moving on to the other concerns. So the left atrial appendage is a source of atrial natriuretic peptide, and it was hypothesized that removal might impair renal clearance of salt and water, and thereby increasing the risk of heart failure. There was another non-randomized study which supported our hypothesis. However, in this trial, they did not observe an increase in hospitalization for heart failure, either after surgery or during long-term follow-up. So moving on to the use of oral anticoagulants. Vitamin K antagonists reduce the risk of stroke by 2/3, and direct oral anticoagulants are even more effective. A risk-benefit analysis in general strongly favors the use of oral anticoagulants, but as I mentioned previously, there are issues with temporary interruptions, incorrect dosing, non-adherence, and then pro-control PINR. The benefit of surgical occlusion is that it could reduce the risk of stroke by a different mean. I mean, it does act by a different mechanism, and its effects appear to be additive. And it also provides a continuous and permanent protection against ischemic stroke provided by the procedure. The other thing of note that they observed was there was a higher risk of stroke in the first 30 days overall as compared to after 30 days, which could be related to the surgery itself, that is aortic and intracardiac manipulation, which increases the risk of stroke anyway. But after the peri-op period, a greater proportion of strokes are caused by the cardiac embolism related to the AF, for which the occlusion was definitely found to be effective. They concluded that while anticoagulation reduces the risk of stroke by approximately 2/3, concomitant inclusion of left atrial appendage reduced the risk by approximately 1/3. The limitations of that trial included the lack of information about the efficacy of left atrial appendage occlusion versus oral anticoagulation. That wasn't the design of the study. That wasn't their target. The findings apply to basically surgical occlusion of the appendage is performed as a concomitant procedure, not a standalone surgical procedure. So if the patient were having the surgery for something else, this was also done. The other thing is the study did not allow us to compare the different methods of occlusion, and did not also examine whether the occlusion was sustained over follow-up. However, all in all, it did show that amongst patients with AF who have undergone cardiac surgery, and most of whom continue to receive ongoing antithrombotic therapy, the risk of stroke or systemic embolism was lower with concomitant left atrial appendage occlusion performed during the surgery than without it. That was it. Any questions, comments?
Why don't we do it more? It just seems like something
Probably should. I mean, I think what they said was they didn't have enough evidence conclusively.
Yeah, I don't know.
And then even if you anticoagulate, if you then patients in 10, 20 years time and start having falls, and then ideally they want to be off anticoagulation, it gives you a long-term benefit.
Sam, any comments? What, any particular reason that they don't do this more regularly, do you think?
No, really. I think the evidence was a bit uncertain, but I think it makes sense to do it if you have a risk, because I think what we need to identify next, if the long-term risk is equal without antithrombotic. So if you have a tissue valve and you give them antithrombotic for a year, then you want to stop it because they have an atrial ligation. That, I think, will make a significant difference to quality of life, really. But I don't think we have that evidence yet.
Do you think there's a surgeon's preference?
It is surgical preference, and most people that will do atrial ligation will do some sort of ablation as well, to hope to go into sinus rhythm, rather than having the atrial ligation by itself. And that's usually can be associated with increased risk of bleeding. Depends on the procedure you do, and the success rate is not great with it as well.
Actually, I haven't since I've been here. I've not seen anyone have like a maze procedure while they're in the theatre.
Yeah.
Yeah.
Surgeons have stopped doing it.
Oh,
They
why?
mostly don't do it. The success rate is poor.
Yeah, I was just about to comment by ablation you mean the surgeon's diathermy and not sitting in the cath lab for 5 hours.
Yeah. Success rate is not great, Eden. If you do a classic maze, it's very high risk of bleeding. And I think some of our surgeons maybe had problems, so they're not doing it as much.
I had a few situations where you had left atrial perforations. And that is bad news. You've got to pull the patient, get them back, and it's very difficult to repair because the left atrium is posterior, just from the esophagus. So it's just a nightmare. So some of them will just say that success rate or risk benefit analysis.
They can't. I mean, even if you're not having cardiac surgery, the cardiologists can put in those devices for atrial appendage closures, can't they?
The revealed.
The things that open up.
Called the revealed. Is a revealed. Yeah. It hasn't been right.
That's I mean, that seems so attractive to not be therapeutically anticoagulated if you're old and you're.
Yeah.
I don't know.
I think it makes sense to not be anticoagulated, and that's what I don't think this kicked out yet, because if you do the classic maze, it's high risk of bleeding, and if you look into the evidence and from what I've seen in practice, I haven't seen two similar mazes. The ones I've seen in Canada and in our center in Glenfield, everyone does a random stuff, and obviously it doesn't work because they haven't done it properly. So I think that's what's putting people off. But if you can combine that cardioversion into sinus rhythm with an atrial ligation, that will stop the need for long-term anticoagulation. It's a very attractive process.
The one thing I've also noted, especially with trying to correct, intervene in AF, is that once your left atrial size becomes too big,
Yeah,
it's impossible. And actually, there's a guideline that from the American College of Surgeons, if you're the SCTS actually, if your left atrial size is more than 6 centimeters, there's absolutely no point. But if you understand that pathophysiology AF is a multifocal, there's multifocal atrial ectopics, and the larger you have a surface area of multifocal development of the more you get AF. And even if you have ablated left atrial appendage, or you've done a PVI or done a MACE procedure, it's more likely to happen.
You still like to get thrombosis in your atrium.
Exactly. So there's no point.
We always go under the toes. You always go looking in the atrial appendage, but I don't know what the incidences of.
yeah. You have to select your patients well as well. Hakeem is right. The bigger the atrium, the less likely. Why the Royal has got cake and we haven't got any?
You're not even eating.
Cake
Was
Friday,
that
Sam.
was that
Always have
discrimination, Zoe?
It is.
You can have cake.
You're gonna send us some in the Hoover.
Probably will get a bit mashed.
Got black, yeah.
There's got to be some advantages to working at the Royal. So all of us can have a shiny new unit.
One of the
Anyway, I'm
few.
in theatre, so I have no cake.
So I just wanted to say thank you to it's Eden's last day today before she heads off to Canada. So I just wanted to say thank you to her for sort of being pretty instrumental in getting this off the ground. And it definitely wouldn't be like this without her. So we hope that's it for us. So yeah.
Thanks, Eden.
Thank you. It's been fun.
Cool. I think we've got Dr. Topham, one of the renal physicians, speaking next week on vasculitis. It's actually really interesting.
Yeah.
Not someone excellent, but yeah, we have someone interesting again next week. And then I believe we might be having a bit of a break for a couple of weeks in the summer.
It's 2 renal weeks.
2 week break.
In
before we
August,
come back.
yeah.
Yeah. And then lots more speakers to come. Yes, thank you very much.
Hang on 1 second. Is that sharing?
No.
Oh, hang on. Is it now?
Yeah.
Okay, that's the feedback QR code. And I put the link in the chat as well. Thank you all. Have a lovely weekend.
You too. Thank you.